Hello, I'm going to be talking about an orthotic case study that I was able to observe while rotating at J&K Orthopedic. Here's a quick overview of my presentation. And starting with the demographics, my patient is a female. She is 5'5" and 165 pounds. She doesn't take any medications currently, and she doesn't have any allergies. She suffered from a fracture of her elbow while doing something in her balcony, and she tripped and fell and fractured her elbow. She ended up needing open reduction and internal fixation of the joints in her elbow, and ended up with a contracture of her left elbow with ICD-10 code of M24.522. She did have an osseous growth, according to my clinician, but it was not heterotrophic ossification. It was just something else. So some of the causes for stiffness of the elbow are varied. For example, in this case, it was a complication of trauma. It's super common to get. Apparently, it's really common to get loss of range of motion at the elbow after even just mild trauma. But it can also be caused by burns, or, like I mentioned before, heterotrophic ossification, which is just bony growth within soft tissues, including muscles or ligaments or other tissues in the joint, or also degenerative arthropathy are some of the common causes for loss of range of motion at the elbow. And the reason why the elbow is at risk is because there are 3 articulations within one capsule. So you have the humeral ulnar joint, the humeral radial joint, and the proximal radial ulnar joint all in one capsule. So anything that affects either of those, any of those joints will affect the entire system. The tightness itself can be attributed to a number of things. For example, capsular or ligament thickening, or musculotendinous and intra-articular adhesions. The normal range of motion that we should have at the elbow is from 30 to 130 degrees of flexion and extension, and 50 degrees of pronation and 50 degrees of supination. And this is just required for any type of midline ADLs like grooming, or also any bimanual activities for like cooking, or just anything you would need both hands to move with. And it's actually really disabling to lose any sort of range of motion at the elbow. And if conservative therapy like physical therapy or bracing fails, then usually they would move on to do surgery to try to release those tendons or the tightness in there. So the patient's elbow is actually fixed at 85 degrees of flexion when it was evaluated. She has 5 degrees available of supination, but no pronation available. And kind of her resting position is just neutral with her thumb facing up. Some of the goals she wants for this brace is that she wants to return to some of her ADLs, mainly grooming type of ADLs, buttoning her shirt. And she specifically mentioned doing her hair. Braiding her hair was something that was important for her, so she wants to be able to return to that. And also, just like I mentioned before, bimanual activities are kind of a big one. Cooking, cleaning, putting stuff away, and also mobilize her elbow in order to get some therapy. Because right now it's harder to do anything because it's stuck at a certain position. So they, just getting even a little bit more range of motion can help them start strengthening her muscles and kind of bringing balance back to the joint. So treatment plan, the device my clinician delivered when I was with him was a JASS, which stands for Joint Active Systems, Easy Elbow. They have a whole line of static progressive type devices, and this one's just specific to the elbow. It addresses both extension and flexion. And the theory, or the idea with this brace, is that you would wear it for 30 minutes. That's kind of like the ideal length of a therapy session for this device. And you would start by tightening a knob on kind of the side of the elbow. The patient would tighten the knob on their device until they felt about a 2 or a 3 on pain scale. I put a little picture down below of a pain scale where 0 would be no stretch and then 10 would be the most painful type stretch. The goal is to kind of be between a 2 and a 3 of stretch intensity. So the patient would tighten that to a 2 or a 3 and then wait 5 minutes and then reevaluate how their the stretch is feeling on their joint, and then either tighten it or loosen it. So every 5 minutes they would reevaluate for a total of 30 minutes. So if the stretch intensity decreased after 5 minutes, then again they would take that knob and tighten it a little bit until again they felt 2 or 3 out of 10 with stretch intensity. If the intensity actually stayed the same, then they would leave it at the same spot for 5 more minutes. They wouldn't increase or decrease the ankle. And if the intensity increased, then they would go back to whatever feels like a 2 or a 3 of the stretch intensity. And ideally, they would work up to that they can do it at least 4 to 6 times a week. And their website actually said that it can be used for up to 3 times a day per direction. So 3 times a day for flexion and 3 times a day to address extension. As long as you waited an hour in between each 30-minute therapy session. And here's a picture of what the device looks like. There's 2 cuffs, one's proximal, one's distal, and they have Velcro that closes kind of like the bivalve type of cuff. They're prefabricated, so they just need a circumferential measurement to determine the correct size for the patient. And the total range of motion that is available with this specific brace is 107 degrees of flexion and 10 degrees of hyperextension, which I thought was interesting that they go into hyperextension. And for this specific patient, they're actually only going to address the flexion contracture first, because that was more important to her, to be able to touch her or do her hair and braid her hair and stuff like that. And patient education with this brace was super important. As I noticed, my clinician spent a lot of time just explaining to her how the brace works, how to do the 5-minute interval up to 30-minute sessions, and also that it was super important for her not to try to tighten it up to a 10 and then wait 30 minutes like that, because it wouldn't be effective therapy. It would actually be counterproductive, because it could actually lead to overstretching and potentially tearing some of the tissues in her elbow, which would not be good for anyone. So the delivery was actually super quick, besides the patient education, which took a little bit longer, but the device is straightforward, it's simple to use, it's really interesting, and they're able to progressively increase their range of motion, and they can, put on the brace for 30 minutes and watch TV or something. Like, they can be sitting down, they don't have to actively be moving their elbow and stuff like that. So I thought it was a really cool brace. So as far as problem solving, this device didn't really need a lot of problem solving, and so I wanted to instead talk about some of the issues that I thought could come up with this device, or just some kind of questions that I had. So the first is, what kind of questions would a follow-up, either phone call or a visit to the office, include? How could you address how the brace is working, how effective it's being, and whether they're being compliant? Also, this device doesn't address pronation or supination at all, which she lost that motion as well. And so I was wondering if there's a device out there that could potentially address both flexion, extension, and pronation, supination at the same time, and whether or not that would be indicated for this patient. Because I was also thinking it could, potentially save her and her insurance money if there was a device that would address all the issues, instead of needing one device for flexion and extension and then another device for pronation, supination, or kind of like what the indications were. Or if there is even a device out there that would address all those issues. And kind of along those same lines, just wondering why they only worked on flexion, the flexion contracture first, when the website for this device specifically says that they can address both motions at the same time. And I guess that's maybe more of a question for the physician who ordered the device for flexion contracture instead of flexion and extension contracture. And finally, because this brace is completely patient controlled, they are able to, decide whether they want to do the stretches the right way, or if they want to crank it all the way up and then potentially injure themselves further. So what would be a strategy to really make sure that patient compliance is going to be there, and that they are going to be able to carry or just follow up with the therapy and make sure that they're not either understretching or overstretching, or if there's anything that us as clinicians could do to address that. So yeah, those are just some of the questions that I had after this brace experience, and here are the references that I used for this presentation, and that would be all. Thank you very much.